we talked about that myeloma is not typically considered curable. And so when it comes back, we have other treatment regimens that we can use. So first, we could use a combination of different treatments from the same drug classes that I talked about before. So we have different agents in those classes that we can rearrange and use. We sometimes can use traditional chemotherapy, which patients respond to. But very excitingly, we've also had approvals of immunotherapies in recent years, including CAR T-cell therapy and bispecific antibody therapies. And these have really improved survival and outcomes for myeloma patients. I'll briefly talk about CAR T-cell therapy. We'll hear more about these a little bit later in the program today, but CAR T-cell therapy stands for chimeric antigen receptor T-cell therapy. What these are that we engineer a patient's own T-cells to be able to recognize a target on the myeloma cell so that when we give those cells back, they can target and kill the myeloma cells. The T-cells are part of the normal immune system. There are two currently approved products in myeloma. They both target the same thing on the surface of the myeloma cell, which is B-cell maturation antigen, BCMA. And the two products are ide-cel and cilta-cel. And there's been a lot of press around these agents recently because in cilta-cel, there was recently 5-year follow-up data shown that showed actually that a third of patients in 5 years still have not had a relapse of their disease. So this is really exciting, especially in relapsed and refractory patients. There are also other products and other targets under investigation. So both of the currently approved agents target BCMA. There are other BCMA targeting CAR T-cell products that are in development, but there are others that target other surface proteins on the myeloma as well, some that target multiple surface antigens. And so we're really excited about products that are going to continue to come out, hopefully, and continue to improve patient outcomes. Again, we'll hear more about CAR T later, but just from the patient standpoint, what is involved with CAR T-cell therapy? If patients are eligible, then we have apheresis of their T-cells, so collection of those T-cells. Those are then sent to the company for manufacturing. The times vary. And during that time, often patients are restarted on myeloma-directed therapy to control their disease while the CAR T-cells are manufactured. They're then sent back. We give patients low doses of chemotherapy with lymphodepletion, basically to decrease the amount of T-cells in the patient's body to make room for the CAR T-cells to become dominant. We then give the CAR T-cells and then monitor in the hospital at our center. Sometimes they can be given outpatient, but usually inpatient, monitored for short-term and then subsequently long-term toxicities from the CAR T. There are also another type of immunotherapy that have been approved recently in myeloma called bispecific antibodies. They're currently approved. There are actually 4 currently approved products. The ones that are approved are in bold here. The way that these work is that this is actually a therapeutic antibody, and one arm actually sticks to the myeloma cell, to a protein on the myeloma cell surface. The other binds to a T cell, and it brings them together so that the T cell, which is an immune cell, can kill the myeloma cells. And as I said, there are 4 approved products, 3 of which target BCMA, B-cell maturation antigen, and 1 talquetamab that targets GPRC5D. Right now, these are currently approved for 4 or more lines of therapy in myeloma, so later lines with patients that have refractory or relapsed disease. But they are again being investigated in earlier lines of therapy in combination. There are now tri-specific antibodies that target multiple cell surface proteins, and all of these things are under investigation. So we're really, again, very excited to see what's going to come with bispecific antibodies and how we can continue to improve outcomes for our patients. I want to conclude with this slide about prognosis. And so what I want to point out is the 5-year survival in myeloma is about 62.4%. But as you can see, this is older data. This is from 2015 to 2021. So this is data from before the advent of any of the immunotherapies that we're currently using in myeloma. So what I really want people to leave with is that, myeloma, while it's not curable, is treatable over many years with therapies that are generally very tolerable. And so what our goal will continue to be in myeloma is to improve not only quantity of life to keep patients living longer, but also to improve quality, right? So to make all of those therapies that we're using to decrease the long-term toxicity of those and keep patients living well for their additional years. As you can see here in this chart on the right, the deaths related to myeloma have been decreasing since the 90s. And so again, we're working very hard to continue to improve those outcomes. And so with that, I will pause and we'll continue with the program.